This week on the BackTable podcast.
So usually use a nitinol wire, like an 018 wire. Initially, that's what is going to coil up inside the balloon, and then an Amplatz wire. You want something stiff. So once you get the dilator into the esophagus, you then can swap out you're using a transitional dilator. So use the nitinol wire and then pull that out with the dilator and then put in an Amplatz wire. You can use a Rosen as well. It's just something a little stiff because the esophagus will move around a little bit. So you want to be able to dilate nicely. And then, usually just one step dilation to 14 French and then putting in the 14 French tube.
Oh man. Yeah. That's slick.
Yeah. It doesn't take long at all. Yeah.
Right? Yeah.
Yeah.
Welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. Now, a quick word from our sponsor.
Discover the Medtronic solutions for peripheral embolization. Concerto detachable coils are available in complex shape for framing and helical shape for filling. The MVP microvascular plug comes in sizes from 3 to 9, with 3 and 5 being microcatheter compatible. Learn more at www.medtronic.com/embolization. Now, back to the episode.
My guest for today is Dr. Peter Bream. He's an interventional radiologist. He started his career at Vanderbilt and then spent some time at UNC, and now he is in private practice. Dr. Bream, welcome to the show.
Thank you, Allie. I'm thrilled to be here.
It's really cool that I get to interview you two because I feel like I have the least chops out of all the BackTable folks to interview you. For those who don't know, Dr. Bream is the progenitor of all the BackTable folks. Chris, Mike, and Aaron all trained under him. But we got to talking and we started talking a little bit about a really good topic. And so our topic for today is going to be all things enteral access. Get ready. Buckle in.
Not a very sexy topic, but it's something that throughout my whole career, I see tons of people who don't understand, that are afraid of enteral access. And I have spent a lot of time thinking about this, and I think it's going to be, I've got some pearls here to talk about today that I think will help. And this is bread and butter IR. This isn't sexy. Yeah. This is not an RA sucking clots out of the lungs or Y90 or destroying tumors. This is just the boring stuff but this stuff comes up time and time and time again.
Yeah, I don't think there's a day in my career that I haven't had to deal with something about enteral access. And I'm sure plenty of my colleagues are the same way. So let's just start with basics. What are the different types of tubes?
Well, when you're talking about enteral access, you're talking about any type of a tube that's going to go into the digestive system. So everything from a nasogastric tube and going straight to, say, just a G tube or a gastric tube that's going to go into the stomach. And we're going to talk mainly about those because those are the most popular. And that's something that actually interventional radiologists are placing a ton of. We really have taken over the market share in that. In some patients, you need to do what's called a gastrojejunal tube, which a GJ tube, we'll probably call it now, which goes into the stomach, but then is long, and you feed actually in the duodenum, the proximal jejunum, ideally. There's the J tube or the jejunal tube, which is either placed percutaneous, endoscopically, or surgically, where there's a tube directly into a loop of jejunum. There's the cecostomy, which has a very special purpose. It's a tube that is placed directly into the cecum, most commonly used in kids with Hirschsprung's or any type of colonic issue, Ogilvy's or anything like that. And it's used for a antegrade enema. They actually fill the cecum up with fluid and enema, and it helps flush everything out. They're not really used for feeding because you don't absorb anything in the colon, but it's a life changer for these patients. And then finally, a really interesting type of feeding tube called a PTEG, or Percutaneous Transesophageal Gastrostomy. And that is a special type of tube where there really is no window to the stomach. And we'll talk about that a little bit later about how you actually place one of those. It could be a life changer for certain patients. It's not for everybody, obviously.
Let's just kind of start with some of the basics. For NG tubes, any just like quick tips or tricks or pearls about those? For usually they're placed by nurses right on the floor, but then at least places where I work, if the nurses fail, then they get sent down to IR so we can try.
Absolutely. Yeah. And, it's really interesting. A lot of these are weighted tubes and they don't work well with wires. We're used to putting a wire into navigating to wherever we want to go and then sliding a tube over that. And these don't work that well for that. So the first thing is there are ones that do have an end hole. And so there are tubes that you can navigate using your standard catheter and wire. Use a Compi catheter, an MPA, get exactly where you want to, and then slide this catheter over there. I remember in residency spending a lot of time doing these in fluoro, as a radiology resident, not so much in IR. And there's tons of issues with those. You can inject some air to get things moving fast, inject a little bit of contrast, but they can actually be a real big challenge. I just use a glide wire and a angled catheter like an MPA or a Compi, Berenstein, whatever, and navigate through that way.
Okay, cool. Just that's pretty basic. Any other things you want us to know about NG tubes before we move on to the meat of this session?
No, I think that there needs to be good communication between the floor and you. If they keep clogging these up by putting pills or anything through them, that's not a huge problem, but it can be a recurrent problem. And it's usually something on the floor that you need to communicate with.
Okay, well, let's get to what we kind of came here to talk about, G-tubes. Let's just start by talking a little bit about the different placement techniques.
We're talking about percutaneous. We're not talking about endoscopic. We're not talking about surgical. And we're talking about what most IRs do. The classic one is the Wills-Oglesby tube. And that was what I placed in my fellowship starting in the early 2000s. Unfortunately, it was a 12 or 14 French pigtail. And it was placed exactly like you would think. It's placed just like if you were going to place a pigtail into the nephrostomy or a pigtail into an abscess. You basically use a needle, puncture into the skin, after using numbing medication, put a wire in, dilate with a standard dilator, and put this tube in. Wills-Oglesby, I actually did a little research on this and just found out they were two radiologists from Delaware. In 1983, they published a paper with 7 patients where they put this pigtail directly into the stomach, and that was groundbreaking at the time. And that grew through a number of different techniques. And most IRs these days will place either a balloon tip tube or a pull tube, and we'll talk about that in just a second, as opposed to a pigtail. Pigtails were notorious for being clogged because they were so small. The routine was you would put them in, and then 4 weeks later, you would exchange them over a wire, dilate the tract up, and put in a larger balloon tip tube. And that was kind of standard practice in the early 2000s. As we got more adept with peel-away sheaths and T-fasteners and things like that, we were able to put larger bore tubes, and that changed everything as far as the clogging issues and the inadvertent removal. There's an interesting article in 2018 from the Penn group, Tishfield et al. That was in abdominal radiology. It's very interesting. When I was doing my research, a lot of the G-tube articles are not in JVIR. They're not in IR. They're in abdominal radiology or something like that.
Yeah, that's because it's not like sexy IR stuff, right? So it doesn't get published in JVIR.
Exactly.
And I think like where I trained, the body division was placing all the G tubes. So maybe that's kind of, so it's that's like their scope, right?
Right.
So they get it into it. But then I feel like out in the community, IRs are placing them all.
Correct. Or, exactly. This was an interesting article because they compared pigtail tubes, which in 2018 were still being placed by this group, balloon tip tubes, and then pull type tubes that have a mushroom retainer. What I found was very interesting. I mean, and there was a lot of patients. They did 1,500 patients in this article. It was from 2005 to 2016 when they placed these tubes. 750 balloon tubes, 300 something pigtails, and 400 pull tubes. So a nice sample across all. They only did 30-day follow-up because at 30 days, all the pigtails were changed over to the balloon tips. So that's why they only did a 30-day. But what they found that overall complications, the loop retained or the pigtails only had a 1.5% complication rate as opposed to a 6% complication rate with the balloon tips and 4% for a pull tube. And so the old adage of, pigtails, don't use them anymore. They actually proved in this study. Now, this was, again, only for 30 days, but it was interesting. And then when you really dig into reading the paper, you find out that actually was almost 95% males. And the reason was it was at a VA hospital. And this one VA hospital, it was just standard of care to do the pigtails. And throughout my whole career, you go to SIR, you go to these meetings, and somebody gets up and talks about how there are incredible results for what they're doing, whatever it is. But you can't repeat that at your own institution because they have everything put in place for follow-up care. So I think that this works really good. The pigtail works really good at the VA, but it wouldn't work well maybe for my hospital or for wherever I'm placing them. So it's just an interesting aside. I might be getting in the weeds here a little bit.
No, I mean, that's such a good point, right? Because can you give me an example of maybe something you tried to, this is not about G-tubes at all, but you tried to implement where you were and you were like, oh, this should work really well based on everything I'm reading about. And then you get there and you're like, this isn't working at all.
Correct. I have a great example. So when I moved from Vanderbilt to UNC, we were placing the temporary dialysis catheters in patients. And we had ICU patients who we would put a double lumen temporary dialysis catheter, 13 French dialysis catheter, and then a 7 French triple lumen in the other side. And where I had come from, we had placed the triple lumen dialysis catheter, the trialysis. So I got to UNC and I was like, why are we putting 2 catheters in when we only need to put 1 in? And it literally took close to 12 months to get through all the committees, to get through everything, to get it actually implemented. And now we're using triple lumen ones, but it just seems so counterintuitive to me. Why would you place 2 catheters when 1 will do the trick? And nobody had ever even asked a question.
And everyone's like, well, that's just how we've done it,
Exactly. In fact, everybody knows Bob Dixon, who's there for many, many years. They actually called it there was like a catheter that was called the Dixon catheter. And it was because that's how they always had placed it. So, but very, very, so that's a good example of that sort of stuff.
Well, but sounds like you pushed that one through. So awesome. Nice work.
But it took a lot of work. It really did.
We got a little off topic, but basically talking to the placement techniques.
Right. So I was talking about pigtail, which basically is like an abscess drain. Probably the most common way that they're placed is with a peel away sheath or dilator. And you either use serial dilators to get to a large peel away sheath, and to put in a balloon tip catheter, like your standard Avanos catheter, you have to go 4 French sizes larger than the catheter. So if you're going to be putting in a 20 French G tube, you need a 24 French peel away sheath. If you're going to be putting in an 18, you need a 22. So Avanos came out with, probably about 10 years now ago, this telescoping dilator. And that is, you either love that thing or you hate it. I'm not a fan for a number of reasons, but because I think that there's a better way of doing it. I'll talk in a minute.
Do you think that it has an increased risk of perforation when you use the telescoping dilator?
First of all, I find it very hard to actually use the telescoping. When I talk to most people, they just push the whole thing in, as opposed to doing the telescoping. The telescoping was a great idea. This actually is based on an older design, an Amplatz dilator set that was used to dilate up kidneys. And you would put an 8 French Teflon tube into the kidney, and then you would slide these dilators over, and they would, then you go to 10 French, then you go to 12 French, but there was like a set of 15 dilators to get up to 24 French. So they kind of took that whole thing and put it all in one device. And it's great. It's long. And this is the thing that I've noticed. Unless you put the wire down into the duodenum, which is a whole extra step if you're going to be putting in a G-tube, most people will take it and coil it up in the fundus of the stomach, because the tip before the tip that you get in, that you slide the dilators over, it's 10, 15 centimeters long. So to get that all the way in and get enough purchase, you have to coil the loop up in the stomach. And that's one of my pet peeves. One of the reasons why when you have an endoscopy tube, because that's the direction that the tube, and you need to convert it to a GJ tube. And we can talk about all the techniques for that down the road, but that it kind of forces people to be able to do that, to put it up into the fundus of the stomach, and because of just the space. So, but it works. I actually have used it many times to do a primary GJ tube when you know you're going to be putting in a GJ tube. But again, the wire's already into the jejunum by the time you're dilating to put that up. And then the final one, Cook makes a kit. I think Bard makes a kit. I'm not sure. Or Boston Sci makes a kit, which is just a big peel away sheath. And so you you dilate with multiple dilators and then put in this large peel away sheath. But I want to talk about the bag. I want to talk about the balloon-assisted gastrostomy, which I take credit for inventing. Actually, in doing a little bit of research here, there were some steps that I was not aware of when I kind of came up with this concept. But the basic idea is you use a standard angioplasty balloon to dilate the tract radially, not pushing forward, and then use that to actually slide the tube in once you've created the hole. And I came up with this concept based on when I was in my fellowship. One of my mentors was a guy named Jeet Sandhu, and Jeet was at UNC when I did my fellowship, and he was working on putting in these 30 French Argyle chest tubes into the pancreatic bed when somebody had rip-roaring necrotic pancreatitis. We all know how difficult it is.
Sure, yeah, to manage that with drains, yeah.
Exactly, because it always gets clogged up. So he came up with this idea, if I put a huge pipe in there and then actually put a pigtail alongside it, you could flush through the pigtail and draw from the 30 French tube, and you did almost like a percutaneous necrosectomy. I mean, you basically got tissue out by doing that. But his problem was, how do I get this blunt chest tube into the retroperitoneum? And what he figured out was he would put a needle in, put a wire in, normally like you would normally get into an abscess, and then he would put an angioplasty balloon. And he would dilate the tract with an angioplasty balloon, and then he pulled it back into the Argyle, blew up the balloon partially, and that kind of made a cone, and then he was able to push it up through. And so probably 2005, I think, I started my career at Vandy at 2001. 2005, I was placing Wills Oglesby tubes at Vanderbilt. We were not placing a ton. The endoscopists were placing most of them. And I was contacted by the ENT division that was doing the head and neck cancers, saying, we would love for you to place our tubes. There were some logistical issues why the endoscopy was taking too long and things like that. But we don't like the little tubes you place. Can you place anything bigger? And again, at the time, telescoping dilator was not available at that time. And so I came up with this idea of using a 10 millimeter balloon and a 20 French G tube, because I chose 20 French because that was the size that the endoscopists were placing. I did the G tube exactly like everybody else. I used 2 T fasteners. I inflated the stomach. I did all that sort of stuff, put the needle in, put the wire in, and then I dilated the tract with this angioplasty balloon. Now, this was a 10 by 4 centimeter balloon.
And this was just like not a high pressure balloon, just like a regular
just a
whatever.
Standard, yes,
okay.
It was one of the Cordis balloons that we were using that was just off the shelf. Back in 2005, we didn't have a Conquest or anything like that. So I did that. And then I did the same thing that Jeet did. I pulled the balloon back into the G tube and partially inflated it, and then kind of pushed the whole thing through into the stomach. And it worked. And I started placing them, and it's one of those things. If you provide the service, it will come. And next thing you know, we were putting in a lot of tubes for that. And I was in an abstract. We did an abstract for Toronto SIR 2007, and had an abstract where I compared 50 Wills Ogilvy's tubes to 50 of my balloon tip tubes using the balloon technique. No difference in complication rates, except that the Wills Oglesby tubes were clogged much more commonly, significantly, and fell out more significantly. So it worked. And then over the years, I've developed, I think the best thing I ever did was I put together a YouTube video.
Yes.
And
how many million views does that YouTube video have?
I wish it was million.
I watch it all the time. And
Oh,
if I'm if I'm like somewhere new and I have to explain this to the techs and staff, I'm like, just watch this, you know?
I need to update it though. I think it's from like 2015 or something, and it's almost 10 years old. I really need to update it. But that was just crazy because I actually I tried a couple of times to get this published. I did a series of 273 patients, and I followed them, and I did all the right things, and I would send it into I sent in JVIR, sent into CVIR, all this sort of stuff, and they basically said, "Well, duh, this is not new. This is, and I'm like, it's never been published before." But luckily, a group in I think it was Spain did finally put together a series of patients, improve the efficacy of the bag technique, and they gave me credit at it too, which I thought was pretty
nice. Cool. So where do you see where can people go wrong with the bag technique?
Great, yeah. So the first thing is making sure that the stomach is inflated enough. You really need to, and I'm a big proponent of glucagon. I give 0.5. So your maximum dose of glucagon is 1 milligram, but that's usually overkill. 0.5 or 0.25 milligrams will actually provide somewhere in the range of 7 to 14 minutes of gastroparesis. And so I always start, and it's onset of actions like within seconds. So it's like 60 seconds to 90 seconds. So right after everything's ready to go, and I'm about ready to put in my first T fasteners, we give the glucagon, wait about 60, 90 seconds, and then inflate the stomach. If you inflate the stomach before that, the stomach's going to respond to the explode and then start pushing it through. And now your duodenum's full of air, and it can obscure things.
So just to summarize that, you give glucagon, wait 60 seconds, then have your nurse or tech start inflating.
Correct. And you can do that anyway. We usually just use a 60 cc syringe with room air. And I usually ask them to do 10 pumps. So 600 cc's of air, usually. And then look at it under fluoro and make sure that you should not be able to see rugae, right? It should be distended enough that you don't see rugae. Choose your spot, which is usually about 2/3 down the stomach. If you look at the stomach as kind of a J shape there, you want to be right at the corner of the J. I used 2 T fasteners if the patient was normal size. If the patient was rather large, I would do 3 T fasteners. I know some people use 1, some people use up to 4. That's just local practice, and there's nothing wrong with that.
Do you have a preference for the type of T fasteners that you use?
Yeah, so I'm only aware of 3 that are, and actually the Brown-Muellers probably are not on the market anymore. The Brown-Mueller is what I used at the beginning, and that used like crimped. It was wire and cotton pledgets, and it was permanent. You had to actually come back and cut it off. I use the Avanos ones that they either come in the kit of the telescoping dilator, or you can actually order them separately. And when I do a bag, we can get them separate. And I like those because they're very easy to use as far as the little disc and clamping the disc down. And if you choose to leave them in, and we can talk about that in a minute too, if you choose to leave them in, they dissolve and they fall off. The old Cope set from Cook, those are permanent, and you have to cut those off at a later time as well. So I just use the ones that come in the kit. And so once you've got that, the next thing is I use an 18 gauge needle. I always puncture towards the outflow of the stomach, towards the antrum of the stomach. And then it's very important to use a stiff wire. I usually used an Amplatz wire, Amplatz super stiff, and I would make sure that the wire coiled and either went into the duodenum or at least coiled back on itself. I want all the forces of the stomach of the placing the tube to be in that direction, so that if in the future you ever need to go to a GJ tube, you can exchange it easily. And then the next step is there's 2 balloons that I kind of settled on. The one that I was using was the Mustang high pressure balloon. It's not ultra high pressure. For those, I would use a Conquest. But what was nice about both the Conquest and the Mustang is they came on short shafts. So I would use a 40 centimeter shaft, and that way you're not reaching all the way at the end of the table to hold the wire. You can hold everything. So what you do is you put the balloon inside the G tube and then have it sticking out the end of the G tube. You then, after you have your impulse wire in, I don't pre-dilate. You can use just the balloon to dilate. You put the balloon in, and what you want to do is you want to have the nose of the balloon far enough inside so that you have enough purchase to be able to dilate the tract of the stomach, the muscle of the stomach. But then the back of the balloon is still on the back of the back of the tube is still on the balloon. So to do that, you need an 8-centimeter balloon. And so we will use, and then the size of balloon depends on what size tube you want to place. So if you want to place a 16 French tube, you would use a 7-millimeter wide by 8-centimeter long tube. If you wanted to place an 18, you use an 8-millimeter balloon. And then I most commonly place 20 French again. And I found that the 10 was not necessary. You could use a 9-millimeter. So standard is a 9 by 8 by 40 centimeter shaft Mustang. That's what I would use. You dilate. Now, this is very key. You need to use 100% contrast if you're doing a Mustang balloon. The Mustang deflates very quickly. And so if you use 100% contrast, it's more viscous and it deflates slower. And that's important for once you get the balloon dilated, there's a magic little period of time. So you dilate the balloon, you've got the G tube is crimped on the back of the balloon. It's expanded a little bit, but it doesn't damage it or anything. Then you deflate and you hold the back of the balloon and the wire and you just hold forward pressure. And what you will feel is there's like a magic little time when the balloon is deflated enough to slide forward, but it has enough contrast in it that you can actually push it. And then if you just keep forward pressure, all of a sudden it'll just fall into the stomach. And that's one thing that people who start using the bag technique tell me. I've had many people, they love that tactile sensation of the balloon, of the tube going actually into the stomach. You can actually feel it pop into the stomach, which is very different from ramming a peel away sheath in and hoping that you're not pushing the stomach away. You can actually kind of feel that. And so if everything goes well, you advance it, you deflate the balloon, you pull everything out, inflate the balloon tip and pull it back and you're done. Occasionally the Mustang, you can't reduce the waist. Like the waist stays there. It stays, it looks like this. And that's either scar tissue or something in the peritoneum or something that is keeping it from expanding. So what I'll do in that situation is I'll still try. So I'll deflate the balloon, push forward. And a lot of times you can actually get the tube all the way down to the stomach wall. It won't go into the stomach because that little lip is too much to go all the way in the stomach. And so then I just pull the balloon back a little bit and reinflate and try it again. And I'll do that up to 2 more times. And a lot of times that's all you need. If you still can't get it in, if you're down and you can't get it all the way in, there's 2 other techniques that I've used. I pulled everything out and I have taken a 15 blade and just gone down the wire and made a little nick. And that, whatever little scar tissue, whatever was holding it together, if you just then repeat the whole process, it works. Sometimes I'll change out for a conquest and just crank it up to 40 atmospheres. And I have not met a stomach that I couldn't get into with that. But that's a little more expensive. If you want to save some money, just get a peel away sheath. And you've already dilated it almost completely. Put the peel away sheath in after you've dilated and do it like a standard way. So that's the bag. I think, a couple of those little pearls about using the 100% contrast. Now, don't use 100% contrast if you're using Conquest because you'll be there all day trying to deflate it because it deflates a lot slower. So,
And then have you had issues getting the Conquest balloon on the 40 centimeter shaft, like since you've been in private practice at all?
Yeah, I mean, it's hard. Yeah. And it doesn't mean you can't use the long shaft. It's just ergonomically, I love being able to hold the wire. I'm holding the wire up here like this and sliding the G tube in over the wire and it just it goes right in. So it's a little harder when you have to, I'm short, so I wouldn't be able to reach, hold up high.
And then have you seen any G tubes where you can't use the bag technique either because of adapters or anything like that?
So too small. So 16 is the smallest you can use. And I have not been able to do this with a GJ tube. The GJ tube, even the 22 French GJ tube, because it's a double lumen tube, the balloon won't fit through the shaft. It just won't go So if you're trying to do a 14 balloon, you can't get the angioplasty balloon inside of the tube. So that's one of the limitations. The other limitations is, let's say you have a stroke patient who's obese. And if you have, 10 centimeters of tissue between the stomach and
Sure.
you've got an 8-centimeter balloon, you're not going to be able to get it in. And so some of the very large patients that we were doing for strokes, I would just go straight to a peel away sheet. Sometimes I would pre-dilate with the balloon and just see if it works. And if it didn't work, then put a peel away sheet in. But everybody else, it seems to work really well.
Very cool. Yeah. I mean, there's just so much that little things about that technique that you just gave to us that it's going to make it so much easier for everyone listening to this show.
Yeah. And I would encourage you to try it. It's, again, it is, and the other thing we didn't really talk about is that the motion of stretching the stomach this way, as opposed to pushing a dilator through, is more comfortable for the patient. So in special populations of patients, such as motor neuron disease or ALS patients that you do not want to heavily sedate or do under general anesthesia, or head and neck patients that may have a class 4 airway that you don't want to sedate, I've done many, many, many of these with just numbing medication. You do not need to have moderate sedation. And it's really a game changer. And if I was still in academics, I would do this paper of comparing the pain
levels.
With pain levels of the procedure.
Yeah.
But intuitively, and if you actually do it with your patient, you'll see. So
I think, and people are always really impressed about how much faster it is than doing all the dilators. Like, I feel like people are always like, what, you're done? That's amazing. So
4 minutes and 53 seconds, I think is my, is skin to skin is my best.
Awesome. Not that you're counting.
Right. All right. Well, Dave Morrow told me I had 5 minutes to do this procedure. So I did.
You're like, oh, it's on, Dave.
It's on. I think the last one was the pull through, and pull through is a really excellent technique. It's basically the way that they're done endoscopically, where you, in the basic technique for percutaneous, you do everything that we just talked about except for the T fasteners, blow up the stomach and puncture. And then what you do is you navigate the wire from the stomach up the esophagus and out the mouth. And then once you do that, you can either put a catheter. Eventually, you're going to have a loop snare that is going to go up from the stomach all the way out the mouth. You then attach the G tube, and it comes with a hard plastic cone with a little loop on the end. So you marry those two, the snare with the end of that, and that plastic cone is actually going to be your dilator. And it has, instead of having a balloon on it, it has a mushroom tip. And then what you do is you pull from the stomach and have somebody feed it in through the mouth, and you pull through. It goes all the way through the mouth, all the way, and then that dilator comes through the skin. And then you cut that off and you add the bumper to it and you add the adapter to it.
I think I need to look up what these tubes look like, because I'm having trouble envisioning kind of like how you get that through the mouth and through the esophagus. What's the tube name?
Can I do a plug here?
Yeah, sure.
Check out my chapter in the IR playbook.
Okay,
I have examples of every tube.
Okay.
And we go through every one of these in that chapter. Nikki Keefe invited me to write the chapter in the IR playbook, and so that's a real good resource. That's where most of what I'm talking about today, my research came from.
That's awesome. Yeah, and we can link to it in the show notes so people can know what to buy and where to get it. It's in both editions, right? I have the old edition because
the old edition I was not involved with.
Oh, okay.
But
so on the new edition of it.
Yes, do the new edition, the one that came out last year. So I'm trying. Yeah. So I actually have placed several of the pull tubes. I would place them in patients that need venting. So they're obstructed. I found that the mushroom does a better job of being able to allow a vent than the balloon tip. And then it was my choice when I had to deal with somebody that had ascites. And the reason being is that by coming from the stomach out the skin, you're not pushing things away and having spillage of contents into the ascites and things like that. So it was a good palliative tube for me. And that's when I started placing them. And again, everything's local. I know of practices where they only place pull tubes or they only place pigtails or whatever. So again, it's what you're comfortable with. It's what your system is comfortable with. And they're all safe. Now, that's the thing is if you look at all the papers that compare even endoscopy versus surgery, they're all very safe tubes and they can all be placed.
One thing we didn't talk about with placement is ultrasound. Do you ultrasound before you place these tubes? And if so, what are you looking for?
Yes. So we didn't even talk about the beginning. So I also, because of being when I was in the hospital, it's very easy. Most of these patients who were in the hospital, we would give barium the night before, again, to pacify the transverse colon, because the transverse colon can be anywhere. One thing I didn't talk about or that changed during my career was I was very adamant that you had to have a CT scan before you got a CT scan because I wanted to see the anatomy. And I would look at the CT scan, and if the colon was in front of the stomach, they're done. They have to go to surgery, whatever. I then had a couple of patients where I looked at their CT scan, and like when we were set initially, and I looked at a CT scan from 3 months ago, and the colon's just like totally in front of it. And then I looked at one a month ago, and it's like all the way down in the pelvis. I mean, it's like nowhere near. So I wasn't going to take just a transverse colon in front of the stomach one time. So I would always bring those patients down, give them barium so you could see where it was, bring them down and inflate the stomach and see what happens a lot of times. And what really caught my mind was that endoscopists don't do that. And their rate of puncturing the colon is less than 1%. So they just simply inflate the stomach and they don't have a problem with it. So that dogma of, it's just a CT scan you should cancel the case. I don't believe is true anymore. But you're talking about ultrasound. Yeah. So the other thing is the left lobe of the liver. You want to be able to see where the left lobe of the liver is because it can come all the way across the abdomen. You may need to change your angle. You may need to come in more laterally if necessary, or even more medially. So every patient that would come down, they would get an NG tube if they didn't have one. And then we would ultrasound their left lobe of the liver, and we would mark that on the skin so that you really needed to put ultrasound on the table when you're doing it.
A question for you. Do you feel like when you inflate the stomach, it can move the colon out of the way? Do you feel like the same is true with the liver, or do you just ultrasound before you start inflating?
Yeah. No, we ultrasound before we start, before the patient's prepped. I don't feel like it moves the liver out of the way. I feel that the stomach pops out from underneath the liver and will come to the surface. The one time that I will use ultrasound to actually do the puncture is if somebody cannot get an NG tube. Say they're completely obstructed or they have a leak or something. You don't want to be putting a tube down there. I will use ultrasound, look for the rugae, place a micropuncture set, and then use that as my insufflation. And sometimes, even if you do that, you do not use that for your actual G-tube site. That is simply to inflate the stomach, because once you inflate the stomach, now you can choose a more appropriate site that's closer to the skin and all that sort of stuff. And use all your tools. If you have cone beam CT on your table and you really don't know if that colon's in front of the stomach or not, just do a quick spin.
Just scan it.
Yeah.
Look. Yeah. Better safe than sorry, right? Especially if you have it.
Correct.
How about finding the epigastrics? Is that part of your traditional practice before with the ultrasound?
That has not been part of my traditional, I have not looked for it. I know some people do. Knock on wood, I have not had an issue with that. I do remember a time when there was actually varices, and we got into one of the varices, and it was fine. Place of the tube was fine and everything, but it kept bleeding and kept bleeding, and we ended up having to go and sclerose those varices percutaneously, and that solved the problem. I think that in this area, you're in that watershed zone between the for the enteral mammary and the inferior epigastric. They're very small. I think they might be hard to identify. And then I will say that one of my worst complications was when I was dealing with an ALS patient whose stomach was very high in their chest, and they were very scaphoid. So I was actually sticking up through the bottom of the stomach. And of course, I stuck right across gastroepiploic. We put the tube in, and I blew up the balloon. I deflated the balloon, and the whole abdomen welled up with blood. I mean, it was just like pouring out. So I knew something was wrong. I placed the tube quickly, did a cone beam CT, saw blood in the abdomen, prepped their groin, went in and then embolized the gastroepiploic at that point.
Oh my
So,
goodness.
but
Yeah.
that was just because I was really pushing the limits on being able to put a G tube in this ALS patient. So
Yeah. We didn't really talk about that, but too, with colon in the way, liver in the way, or like too high up in the stomach, those are, or too high up in the chest. Those are all reasons why maybe you switch to a surgical approach, right?
correct. Yeah. You certainly don't want to place between ribs, but I do find, especially in thin patients, that you can angle the II so that you're parallel with, normally people are like this. Well, if their stomach's like this, why stick down this way? You want to stick perpendicular. So I will angle the II, and then magically, when you're holding your needle up there and you see where the stomach is, the colon goes away and everything, and you have a nice, safe path.
Oh gosh, it's such a simple thing, but I've never thought about that. Just, just angling, go a little cranial, see if you find a spot. That's awesome.
Exactly. Yeah.
Okay. I think we kind of beat that horse to death.
We beat it to death. Yes. Well, you got me talking about bags. So.
Oh, hey, will you talk about PTEG?
Yes. Let's talk about PTEG. I've only done maybe 4 or 5 of them. Okay. Because they're very special. But basically, if you have somebody who has, let's say, abdominal mets, right, in front of their stomach, or they have ascites that you can't reduce, or their stomach is way up in their chest and there's just no way to do it surgically, anything. So this was developed in Japan. And basically what you do is most of these patients will have an NG tube because that's the only way that they're usually obstructed and they're just intractably vomiting. So they have this NG tube, but then of course their nose starts to erode and it's just terrible. So to palliate them, you want to get a tube into their stomach through the skin that is not through the mouth or through the nose. And so the way you do that is you exchange your NG tube for a wire. So now you have a wire into the stomach from the nose. And then you take an 18 millimeter balloon and you put the balloon into the esophagus and inflate it. Then you pull it back until it comes back up and will stop at the upper part of the esophagus here. Then you use ultrasound, and you usually do on the left side. And by ultrasound, you can actually find a path lateral to the jugular and the carotid behind, and you can actually see the balloon with your ultrasound. And so then you take a needle and you puncture the balloon and you feed a wire inside of the balloon. Then push the balloon forward and it drags the wire down into the stomach. You release the wire by putting a dilator in through your skin. And we used, just your standard PTC dilator, MacNav or whatever you use, 6-French dilator. Pull out the NG tube and pull out the balloon. And now you have a wire that's going through the skin, into the esophagus and down into the stomach. And now it's just a matter of dilating it and placing a 40 centimeter pigtail. We usually used a 14 French pigtail. And you will have the happiest patient you've ever met in your entire life. It seems weird having a tube coming out of the side of their neck, but what they have been dealing with throwing up all the time and complete nausea, it transforms their lives.
That's really wild. That's like a pretty interesting technique. Yeah. What kind of complications do you see with those tubes?
Infection tends to be a little bit of an issue. This is not a great area, kind of like you would deal with any type of central venous access. You're basically coming more lateral than that, so infection can be an issue. Again, antibiotics and stuff usually will keep that from becoming an issue or a major issue. There have been reports, and actually we had a case at UNC where we nicked an artery going in and we had to go in and embolize that. But again, you can lay everything out with ultrasound and find a safe path. And then you're just using a 21 gauge needle, pop right in.
That's really neat.
Yeah.
That is a super cool procedure. Anything else you want to tell us about PTEGs? What kind of wires do you use to go in?
So usually use a nitinol wire, like an 018 wire. Initially, that's what is going to coil up inside the balloon. And then an Amplatz wire. You want something stiff. So once you get the dilator into the esophagus, you then can swap out you're using a transitional dilator. So you use the nitinol wire and then pull that out with the dilator and then put in an Amplatz wire. You can use a Rosen as well. It's just something a little stiff because the esophagus will move around a little bit. So you want to be able to dilate nicely. And then, usually just 1-step dilation to 14 French and then putting in the 14 French tube.
Oh man. Yeah. That's slick.
Yeah, it doesn't take long at all. Yeah.
Right? Yeah. Well, cool. I think we talked a lot about insertion techniques, insertion pearls. Yeah, we talked about the tactile sensation, making the incisions large enough. You wanted to talk to me a little bit about T-tacks, and do you keep them or do you take them out?
Yeah, so I have seen the T fasteners evolve over the years. The Brown-Muellers were a necessary evil. I don't. Have
Mm-hmm.
you ever seen a Brown-Mueller
That
T
was before
fastener?
my time. No.
So
What were those like?
so they were loaded on a wire. Loaded on a needle. You would puncture into the stomach with it, and then you would run a wire through it, and it would pop the T fastener out. But it was on a metal wire that came out to a cotton, like a round cotton pledget, basically a large cotton pledget. And then you would take your needle drivers and you would crimp a little crimping metal device on the outside. And that's what held everything together. And you really had to have those patients come back because we had several come back that were so nasty because they had not been removed in 6 months. But because they're metal, they don't dissolve or anything. So those were the Brown-Muellers, which again, at the time we didn't have much other than the Cope set. And so we used those. But the new ones, the ones that Abno sells now with the absorbables suture is great. What I've learned is that by putting a G-tube in that has a disc on the outside and a balloon on the inside, the T-fastener really doesn't add much to forming that bond between the stomach and the abdominal wall that you want to do before you can exchange it. And I'm blanking on his name, but there's a really good paper out of Michigan a few years ago, I think 2017 or so, maybe even before that did 400 patients where they took the T-fasteners off immediately after the procedure and had virtually no complications from that. When I did again, it's not published, but when I did my follow-up of the bag to try and prove that it was a viable alternative, my biggest complication rate came from the T-fasteners. Pain, infection, and I was routinely having those patients come back in 2 weeks and remove them. And I had many patients that they had to be removed before that. They hurt. The other thing that we don't realize is that we're placing the T-fastener while the patient's supine. And then they sit up and their stomach pulls down and it actually creates a lot of tension on those T-fasteners. So they pinch and I've got all these pictures in my teaching file of those little discs eroding in and causing infections and causing bruising. So gosh, probably almost 10 years ago, I started cutting them off right after the procedure and then just eliminating that issue. Some people don't feel comfortable with that. And the problem is let's say that something happens and the balloon gets pulled out the next day or something like that, or within the 2-week period. How are you going to get back through? Well, in my patients, 235 patients or 270 patients that I did, that happened very, very infrequent. So I didn't feel like that was enough of an issue. That complication was much, much lower than the complications from the T-fasteners themselves. I always just say that I feel like the T-fasteners cause more problems than they're essential for placing the tube. But once you've placed the tube, I say
Get rid of them. Interesting. Okay. Yeah, I think, like you said, everything's local, right? So if your G-tube patients are going somewhere where the nursing staff isn't going to accidentally deflate the balloon and rip it out, then it makes total sense to take them out at the time. But if maybe the dispo is a little more heterogeneous, then might not be the best idea. Now that you're doing a little bit of locums work, right? And so when you go to like a new place and you do something like that, where you're like, yeah, just take the T-fasteners out, does everyone freak out?
So I have learned, keep my opinions to myself. When you come into a new place and there are established norms. So one of the hospitals I'm covering right now, they only place pigtails for G-tubes. They don't place a balloon tip tube. And I came running in there. I want to place a bag. And I have learned to swallow a bit of pride and just do the way things work for them. But yeah, I mean, that's an issue, right? You want to be able to teach, you want to be able to help, but if the system's not ready for it, it might be that patient would go up to the floor and the nurse would say, oh, well, I don't know how to use this tube. This is not the tube we use. So you don't want to create more problems.
100%. 100%.
Yeah. So you mentioned about the aftercare. When do you start feeding? There's good evidence that you can start feeding these patients either immediately or within 2 to 4 hours. Do you keep the patient overnight? That was our standard practice, keeping every single patient overnight. We never had any complications from that. So there's good evidence that you can do this on an outpatient basis. You watch the patient for a couple of hours after. You test the tube, make sure that it works, put 60 cc's of water into it, ask the patient, does it hurt? That sort of stuff.
Do you do that at the time of the procedure? You put water in?
No,
or is that later?
This is before they go home.
Oh, okay.
Yeah, if you're going to let them go home in a couple hours after the procedure, just make sure that the tube is patent, and you can tell that it's in the stomach by simply holding the tube up, putting that 60 cc's of water in, if it goes in easily, and then have the patient Valsalva, and you'll see the stomach contents rise up in the tube, and you know that you're in the tube.
That's a neat trick and a nice thing to do before discharge. Yeah.
Correct.
Okay. Let's talk about when to start peds. Oh, talk to me about the button tubes.
Yes. Okay. This is another one of my passions, is when I was able to kind of set a protocol and see my patients, before, see them in clinic, and mainly for special populations like ALS and head and neck cancers. But we would see all these patients before in clinic, go through care, maintenance, what was going to happen during the day. We would give them their barium while they were in clinic, and then they were instructed to drink that the night before their procedure. And then they would come in that day. And I tried every single patient to have them come back at 6 weeks and have their tubes changed out for a low profile tube. And the button tube, and the reason is almost all of the complications of leakage, granulation tissue, clogging, and I think that's those can all be resolved with a properly sized low profile tube. And yes, because granulation tissue happens because the tube the bumper is too loose and it's moving in and out and irritating it. And that's where we get the granulation tissue. Leakage happens because either it's too tight, sometimes it can be too tight and tent the stomach, or it's too loose. Now, if it's properly done and you have leakage, and I don't know if you want to go into that, but that's gastric outlet obstruction. And that has to be
I want to talk about like some special scenarios later.
Okay.
Yeah. Like I want to give you some like, okay, what do we do when this happens? So we'll get to that stuff. But tell me how you size the mini tubes.
So I would record at the end of my procedure of putting in the G tube. Before I cinch down the disc, I would hold the tube up, not under a lot of tension, just hold it up. And all the tubes have markers on them. And I would record in the chart what we call the stoma size was. And then when they would come back, we would use the tube that they have in place to make sure that stoma size has not gotten larger or smaller, and then choose it based on the tube that they have in place. Rarely did we have to use the sizing thing. Now, obviously, if the tube had come out or it was from another institution where we had no idea, we might use the sizing tube. But you definitely want to have it so that it's not dimpling the skin, but also not freely loose. So you want it in between that. And they come in half centimeter sizes, from 0.5 to, actually I've seen a 6 centimeter low profile. Yeah.
Yeah. Oh, any reasons why you wouldn't place it as the initial G tube?
Yeah. So, there are some papers out there that say that can be successfully done. I found that most of the patients that I was doing the reason we were putting this in was because they had lost a ton of weight. And I felt like if I put in a tube that they were going to actually gain weight, and then the tube would be too tight. And so I found that most patients with a proper nutrition regime where they've seen a nutritionist and they calculate their caloric intake evened out around 6 weeks. And so the tract was mature, and they were not going to change the size of their tract by 6 weeks. And so that's why I chose 6 weeks.
Okay. Do you recommend routine gastrostomy tube exchanges? And if so, how often?
Yeah. So that's the other reason to do a low profile It's not uncommon for the low profile or the button tube to last for a full year with no problems.
Wow. Okay.
And that was our standard, was either 6 months or a year, a routine change. Obviously, this is just like in anything else. You want to be able to exchange this before it's an issue, right? You don't want to have at 5 o'clock on a Friday afternoon, person come in that you have to unclog their G-tube or replace it or whatever. So standard was 3 months for your standard tube and 6 months for a low profile tube. I also had patients that call me at 6 months, say everything's fine, I'm not going to come in, and I'll be like, fine, as long as it's working and you're doing well. But that's what's nice about the button tube is the tube length is only 2 centimeters. So actually declogging them is a lot easier. And then any issues are usually in that long period that's outside the skin.
Okay.
Like
and that can just be replaced out.
And that can be replaced. And they usually have 3 or 4. They can throw that in the dishwasher and wash it so that it stays clean. It's nice. The only time when I've failed with a button tube is if the patient doesn't have the dexterity to be able to put that tube in. They have the dexterity to be able to pour a can of Ensure into a syringe, but putting that tube in and they don't have any caretakers, that's one issue that I've come up with that I'm sorry.
Is there a way to convert a button G-tube to a GJ, or does that exist?
Yes, absolutely. So button GJ tubes absolutely exist. They have the same sizes. They're just, they're 45 centimeters long as opposed to just that nubbin. So if you have a button, you basically would take that out and then do a GJ tube just like you would do in any other exchange. So, yeah.
Okay, neat. Well, that's kind of like the first part I feel like we have covered, like literally in excruciating detail. Tube placement. I'm here for it. Yes.
Absolutely.
Okay, so that concludes part 1 of Enteral Access Insights. Tune in tomorrow for part 2.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck, Sabine Dong,
Michael Barraza,
And Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and Digital Marketing led by Brian Schmitz.
Social Media and PR by Ann Dang, Manisha Naganathanahali,
And Manbir Singh Sandhu.
Administrative support provided by Jamila Kennebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.